All right, pay attention. She's one of our success stories. You too can be a success story. This is Dr. Karen Ott. She's in Healthcare Quality, DNP. She has been with the VA for 10 years. She is the Director of Policy, Education, and Legislation for the Veterans Administration. She's wonderful. She's one of you, so welcome her.
Thank you. Thank you. Okay. Thank you. I am thrilled to be here. And I'm going to talk a little bit about myself. And then I'm going to tell you what I believe. And I would like to ask you to test my beliefs, because I like to have my beliefs tested. And you're the right group to do that. It's important that you do that. But I understand, I know you are a collective group of MSN and DNP students. Is that correct? So where are the MSN students? Are you sitting together? Mostly. And where are the first year DNP students? And the second year? Oh, so you're not even as a cohort, huh? Yet. That happens with online education, doesn't it? You don't have a clue who your classmates are in person. You just have a virtual relationship with them forever. But that's how work is. That's how work is for me in the VA, because the VA is in every city and state in the United States. So my relationships with my VA colleagues are virtual, permanently virtual. I don't have a clue what some of these people look like for 10 years. Well, let me tell you a little bit about myself. I'm a graduate of 2012 DNP program. I began in 2009. So let me tell you, when I was born and raised in Missouri, St. Louis, Missouri, a landlocked state. I tell you that because I went into the Navy. So it was unusual to go into the Navy because I didn't have any exposure or experience with that. But I graduated from high school in 1970, and I knew I wanted to go into nursing. So I looked for a program, and in the 70s, the only programs pretty much that were open were diploma schools. Very few of my colleagues that I knew went into college for nursing. So I went to a diploma school in 1970 and graduated in 73, and so I was 22 years old. Then I left St. Louis and I joined the Navy. So in 1973, I joined the Navy. We were still in Vietnam, which is hard for me to believe. And I stayed in the Navy for 30 years, and my last duty station was here in Washington, D.C. And then I loved nursing very much, loved federal nursing very much, actually. Pretty much federal nursing was all I knew. But I loved what I did, and I wanted to stay in nursing, so I began to look around for nursing positions as I retired in 2003. Wanted to stay in D.C., and I had a network of nursing colleagues that I had made from my 2 years as a senior nurse an officer in the United States Navy Nurse Corps. So just so happened I was able to have a relationship with the chief nursing officer of the VA at the time, Kathy Rick. I went over to see her, and she offered me a position, and I was mulling it over, and I realized my heart was still with federal nursing and taking care of veterans. So I accepted the position, and I've been at the VA in the Office of Nursing Services ever since. So I made the decision. So that's where briefly what my career was like. So my educational career, I had a diploma, came into the Navy. At the time, you could come into the Navy with a diploma. You can't any longer, of course. And then I got my bachelor. Then every decade, went back to school. So I don't know if anybody my age in the audience has had the same experience. Got my diploma in the 70s, my BSN in the 80s, my master's degree in the 90s, and here was 2009, and I was applying for the doctoral degree. Anybody have that same experience, my age? Anybody? You did? Very long, very painful way to be standing here today, right? Always question myself, why do we do this? Why do nurses? Why? And I still question it today. Why is it that for us to further our education, specialize, why do we have to leave the work setting, maybe leave a salary, and go back to school? Our physician colleagues go through medical school. When they want to specialize, they start their fellowships. Where they start them? In the clinical area, right? They don't leave the hospital. And I look back on my diploma program, and you know what? My diploma program was the closest to a residency that you would ever have. We were on the floor on day one, just like a resident might be, or an intern, medical, and we worked on the floor and then went to class. Came back to the floor, went back to class. So I see that as almost a true residency, but we saw the need for education for colleges. We took ourselves out of that situation. Was that good or bad? I don't know, but here we are today. A lot of my colleagues make a tough decision going back to school at that point, and that's why I believe, it's my first belief, I believe that nursing education should help us look for easier ways to get our education accomplished other than leaving the workplace. Now, I say that. I had to leave the workplace for my bachelor's degree, had to leave the workplace for my master's degree. My doctoral degree, however, was brilliantly done. And one of the reasons I picked GW, first of all, I needed an online program because I was working, I was traveling, and it made sense for me. Second of all, GW, the doctoral program, insisted that I use my work, insisted on it, that I use my work. It was, of course, that's the right thing to do. And I got a lot of my beliefs challenged when I started at GW, which I loved. And I don't know about you, but my very first semester, I realized quickly, very first semester, that no one cared about my opinion. I used to give my opinion freely. Oh, I've been in nursing for 30 years, and I know this. They said, what does the evidence show? Evidence? This is going to be different. So this is 5 years ago now, so you know I'm already in my late 50s, and I'm thinking, yeah, I wish I had done this a long time ago. But nevertheless, I did it. You're doing it. You're sitting here because you're doing it. It's an amazing terminal degree to caps your nursing proficiency, expertise, and leadership, no matter whether you choose straight clinical or healthcare quality or leadership and management. It doesn't matter because you're still in nursing and you're going to influence nursing. And the only way to influence nursing is to have a degree that's advanced and on par with the colleagues that you're working with. So if you find that you're working and you're sitting at the table and you're the only one without a doctoral degree, get your doctoral degree. It matters. If you're sitting, most of your colleagues have master's degrees, then yes, a master's degree is what you need to have. I found for me, I needed a doctoral degree. It was important, it still is important, and how I encourage the nurses. Now, what we haven't figured out in the VA is, how do you use a doctoral degree when you're still at the point of care, when you're at the unit? You don't necessarily have to leave the unit to use your doctoral degree, but if we don't change nursing to use that doctoral education, even at the point of care, then we've done another grave disservice to nursing. So that's what, second thing I believe. I believe we have to create a role at the point of care for nurses with doctorates, because that is how you will change practice. Third thing I believe is you should never leave an organization without making it better than the way you found it. So the VA has come under fire for, as you know, access issues for the last several months. These issues will go on. It'll have a half-life of 10 years probably, because Congress is Congress is our board of directors. So Congress is very intense on us now. I believe that the VA is capable of changing, and it will. The VA has to change. It has to change for every generation of veterans. Every generation of veterans demands something different. And what I love about the VA and why I came in it 10 years ago is because the VA is capable of changing and meeting the needs of the new generation of veterans. I love when veterans demand things because that makes us change. It forces us to change. So I had certainly had enough years when this latest crisis hit. I could have left. I could have retired. Well, I was paying off my scholarship for my doctoral program, so that doesn't matter. But I could have left. You know, I had enough years to retire. But you know what? I was pleased that we were in this crisis, because crisis, as you know, the symbol in Chinese for crisis is opportunity. You've probably heard that. And chaos is opportunity. So it's an opportunity to change, and I believe that we will change and we'll make care better for veterans. And I love veterans. I love taking care of veterans. I can't see myself doing anything different. So that's why I'm staying in the VA. I need to make it better. Before I leave the VA, I need to make it better for nursing than when I came in. It's a huge challenge for us in our Office of Nursing Services. When I was in the Navy, there was only 3,000 Navy nurses. I say only, very lovingly. There's 55,000 RNs in the VA. And when you add LPNs, and you add APRNs, and you add nursing assistants, our numbers are above 90,000. So there's above 90,000 nursing folks in the VA. That's a large number, and it's a huge challenge for us, but that is my goal. My goal is to make the VA better than when I came in before I leave. And so I would challenge you, wherever you are, in your professional or academic career, I would challenge you that where you work, that you make it better than you found it when you came, and you don't leave until you do. That's part of your responsibility as a nurse leader. We have many other responsibilities as a professional, certainly changing our profession through evidence, and having the methods and the knowledge and the experience to change practice is what you have to do. So I believe that as professionals, we have to change our practice so that others do not change our practice for us. That is the true mark of a professional. That is what I believe. And having the skills and the methods to change it via research is something that we have to do. So I would challenge you for that. Okay, so I've told you some of my beliefs. Now, I'd like someone to test my beliefs. Anybody want to challenge me on some of those beliefs? I would love to hear your thoughts about nursing and our responsibility as nurses, as practicing nurses, as nursing leaders. Before I do this, let me tell you one more story. When I was in the Navy, I was stationed in, when you are in the Navy, you get orders to go to and by the way, is there anyone here in the military? Active duty? Reservist? Active duty? Air Force? Anybody else? Just retired? Oh, did you? From? Air Force, gotta love them. Yes? Great. Others? Where? Oh, Public Health Service. Excellent. Where was the Navy person? Oh, can't see you. Great. So there's no light on you. Okay, that's great. Well, you know, I did my master's degree full-time duty under instruction, so I was doing this for that. And when I got my doctoral degree, it's the first time I actually had to work and go to school. That was a challenge, but I got through that. When in the military, when you change your duty station, you get a set of orders and you go to a duty station in a particular role, a particular billet. So I graduated from Villanova University with my master's, and I had orders to San Diego, Navy Medical Center, it's a big, huge medical center, as the department head for critical care. So off I went, had no experience in critical care, but that's how the Navy does it. That's how it didn't matter, it didn't seem to matter because, now let me qualify that. The reason that it doesn't matter is because you, in the military, you're there for combat reasons. You're there for combat casualty support. You exist pretty much for combat casualty support. And when you're in combat, you have to do it all, correct? You have to do everything. You can't, specialization is okay. You know, if you're a CRNA, that's one thing. But specialization is okay, but really you're most valuable when you can do more. So, you know, I say that I didn't have any critical care experience, but that didn't stop them from sending me there as the department head for critical care. So I arrived, and lots of nurses there, about 1,000 in the nursing directorate there at San Diego. And the nurse executive there was a gentleman who he was my boss. I was one of many department heads. And he was leaving, going back east, actually back here to Washington, D.C. for a conference, and wanted someone to step in and take his place, be acting nurse executive. So we are sitting around the table, we were in a director's meeting, all his directors are sitting there, department heads. And he said, okay, who wants to fill in for me? And everybody went like this. Because you know what, we were busy. And so I looked up and I was so embarrassed, I said, I'll do it. He goes, okay, great. So I sat in for him, and he came to DC for the week. And when he got back, I briefed him on everything that took place. And that Monday, he had a terrible medical disaster that incapacitated him. He had a bleed. Totally unexpected, actually life-threatening for him, but he survived. So they called me up and they said, "You got to come back in. You have to be placed." I said, his name was Dennis. He said, "You have to take Dennis's place. Dennis is in the hospital." I said, "Dennis who?" Because I had just briefed him on Friday and he was, great. So I found out he had this. So now I'm the nurse executive at San Diego. So I went from being department head, which was so tough, to nurse executive for the entire medical center. It was very difficult. I used to get to work and my headache would start, and it would end when I got home. And the next morning I'd get up, I'd come to work, my headache would start again. I realized I was under a lot of stress. So Dennis survived and wanted to come back. And he went into rehab for a year. So I stayed in that position as nurse executive for a full year without being able to make any changes. So I thought, because when you get in nurse, you want to go, "Oh, I want to make this change." So I couldn't do that because it wouldn't have been fair to Dennis. If he could come back, I didn't want to make changes. So it forced me, it turns out, it was probably the most valuable thing I ever did. We were just talking about that. It forced me to observe and listen and ask questions for a full year without having to make any changes. One or two, but I didn't. And at the end of that year, I had absorbed so much from listening and asking questions and going on to the units and observing what was happening. It was an amazing experience for me for my leadership. I would have never got that had I took over and I said, "Oh, I want to change this." And I learned that was not the right thing to do. It actually it enhanced my leadership beyond anything I could have imagined. So that experience to me probably framed my leadership, I think, going forward. And it might have been the moment that I decided I need doctoral education. I think it probably was. I didn't recognize it at the time. But it was such an important piece of my nursing leadership that I thank God in a way that I was forced to do that. Now, and Dennis was not able to come back, so they asked me to stay on, and I ended up staying on as the nurse executive for 2 more years until I actually came back to Washington for my last career. So, that was a good experience for me, and it tested a lot of my beliefs. But I would watch nursing practice on the units, and I saw things that worried me to death. And the major thing was the gap between the manager and the nurses delivering care, the huge gap. Nurse managers became hire, fire, scheduling, blah, 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 business end. And nurses were, and in the Navy, the average age of nurses, right, 22 is the average age for a nurse because they're all very young. So they're all ensigns in the Navy or second lieutenants in the Air Force or Army. So I watched that, and I realized the gap was there, and I was trying to close that gap, and I worked with my physician colleagues. So it was an amazing experience for me to change nursing, and it helped me create that leadership that I'm still doing now at the VA, trying to do the VA. So those form my beliefs. I have my beliefs tested all the time, but I'm interested in hearing from you if you think differently, if you want to challenge some of those beliefs I've talked about so far this morning. Anybody have a different experience in life? Yes?
Well, not a different experience, but I worked with USDA for like 7 years before I was a nurse, and I know how long it really does take the government to change things, and things come and go, and people forget what's going on. So as far as the VA, and like you said, you definitely believe it will change and can change. What evidence have you seen from where you are that gives you confidence that that's going to happen in a somewhat timely fashion?
What's your definition of timely fashion? I'm just curious.
Okay, that's fair.
A year? 6 months? A year?
No, I understand that it's a huge, and that's what it's such a huge organization, and there's so many facets. And like you said, your board of directors is
Congress, yes, that's right. And they love to get in our backyard and tell us. There are a lot of expectations put on us from Congress, you know, that you will fix this. And they're right, we have to fix it. And we will fix it, we will fix it. And, but when you fix things too quickly, they're not fixed correctly. So you have to walk that line between fixing them too fast because you have a knee-jerk reaction to something, and that's what we're struggling with right now. But there has been so much work done to change our antiquated systems. Like we woke up, oh, our systems are antiquated. We recognize that now, and we have so many work products that we're putting out quickly to turn around. And the first thing we had to turn around was the culture of hiding things from the secretary. Everybody loved the secretary so much, I think they were hiding things from him. They didn't want to tell him when things weren't going right. You got to change that. And the veterans, and then the second thing is engaging those veterans in every decision we made. I think we got away from that, and we're going back to that now. So I think within a year you'll see a major change. That's my prediction, and I'm working on it. That's my, and I am working for my your tax dollars are really hard at work. Yes.
I have a general question. I don't want to challenge beliefs, but how are nurse practitioners helping to meet the needs of the VA, and how will they, in the future, meet the primary care needs of the VA? Because I think that's what they've realized.
Yes. So the question is, how will the VA use nurse practitioners for primary care and for access? And that's an excellent question, because we have been working on that before this crisis came. We do our own version of the medical home in the VA, what we call it Patient Aligned Care Team, or PACT, P-A-C-T. And nurse practitioners are team leaders. So one of the things that we are working hard to do is to have the, let me think this through strategically, because we have so many elements of our nurse practitioners. The first thing that comes to mind is, now because we're in every state, some of our nurse practitioners were licensed in states that had full practice authority, and some had restricted practice authority. So our challenge was that, depending on the VA, the nurse practitioner had a collaborative practice or didn't have to have one. So that was our first challenge. So how we tackled that, and tackling that, is we actually have the authority in the Constitution that's called federal supremacy. And DOD has this as well, because it's all federal. And what that says is that the federal agencies can determine the scope of practice for its clinicians without regard to state. Now, the states don't like this, but they have to recognize that that is our authority. So we had federal supremacy, and have had it for decades, but we never had a policy. So in 2009, we crafted a policy that said all nurse practitioners will have full practice authority regardless of state, because we're in every state. And believe it or not, we have been battling that. Some of our outside stakeholders have been battling us on that for 5 years. But we are determined to get that through. And when we get that through, all nurse practitioners in the VA will be full practice authority regardless of where they live, as long as they're working in that VA. Not when they moonlight. It is really, thank you. It's been hard. It's been hard. It actually is going to go out for public comment, because some of our physician stakeholders who are against this, because they understand that if the VA does this, it's not long before the states follow. Because as you know, 17 states plus the District of Columbia recognize full practice. But once the VA does it, it probably will hasten the states so that all the states will eventually do it. There's no reason why. A Federal Trade Commission has gotten involved. You know, it's an infringement on federal and free trade. So that was first thing. First thing is to get that policy, and it's got to go into public comment in Federal Register, but we're getting there, and we will do it. We will do it. And then I hope that changes the United States. Second of all, our nurse practitioners in the PACT, when they were team leaders, they automatically, the physicians gave them smaller panels. We said, what's up with that? So right now we're working to redesign their panels to give them the same panels sizes as the physicians. And by them having privileges as opposed to going by the state, then they determine the size of their panel based on their experience and their training and their certification. It's an individual thing, not a state thing. So that's what we're working on. So we're working on NPs getting bigger panels, and NPs who work in specialty care doing what they can and what they need to do for their patients without any barriers. So we work really hard on taking some of the barriers away. We are working on that and trying to get NPs up to the level where they are full contributing practitioners for veteran care. So that's more to come. More to come on that. Yes. I think so. May not be, but I can repeat. I don't think this one's on.
How many people does it take to fix a mic?
How many academics?
So I just asked him a question.
It takes one, the answer is it takes one qualified person, right? Clearly, I'm not qualified.
Okay then. Ethan.
I'll repeat your question if, once you
Good
tell.
morning, ma'am.
Good morning.
Good to meet you.
Nice to meet you too.
Also active duty Army, Navy for a long time actually,
Oh.
and switched to Army.
I got it.
I see a high utilization of APRNs. I deployed more with the Navy as a reservist actually, and so much as that I wanted to remain on active duty because I had so many years active duty service.
Right.
So when I approached the Navy, the detailer had no assignments. I put in a packet for Coast Guard and Army and Air Force. It was accepted by all, but Army came through sooner, so I went with that. So
Excellent.
I see a high utilization of us. You
Yes.
know, I just PCS from Walter Reed and had a panel size much larger than my physician providers.
Yeah.
And I had a lot of collateral duties in addition to that, and was expected to stay on top of that.
Right.
Whereas the physician counterparts did not have the same workload that I had. So my problem was capturing that.
Yeah,
They
yes.
utilized the heck out of me, you know, I mean, to the point of burnout, you know, and I asked to get out of there, and now I'm at Fort Belvoir. So I'm not finding a way or a venue or the opportunity to highlight the assets that nurse practitioners bring to
Yes.
military health or
Yep.
within the team at all. What are some of your recommendations?
That's great. Thank you, because I'm glad you said that. And thank you for your service.
Thank you, ma'am. You too. What an honor.
One of the things that we are doing in the VA for NPs is to also create protected time. Because as you said, with our physician colleagues, they always had, it was a given. They
Roger.
had protected time to teach and to do research.
Absolutely.
And the nurse practitioners were seeing patients every 15 minutes.
Right, right.
Okay.
And no protective time.
But no
They
protected
were
time at
very,
all.
very
The expectation was completely
specific
different.
about that is
Yes.
not protected time.
So actually, that is what we're writing in policy, is that there's protected time for nurse practitioners for research and teaching. And we entered into, the VA has entered into academic partnerships throughout the United States with schools of nursing. And the schools of nursing in this partnership give VA nurses some adjunct faculty positions.
Yes.
And in exchange, so they teach, so they come and teach, and they get and the VA must provide that time for them to teach. And in return, the schools are able to take nurses off their waiting list. We're talking mostly undergraduate here. So the VA is doing two things. We're doing this through academic partnerships where they're getting faculty positions and then getting the time to do that. And then we are also putting in policy that protected time exists, because I agree with you.
Yes, ma'am. One last question.
Yeah.
What do you think that maybe I may be able to do? I'm the deputy director of an inpatient behavioral health unit presently, and I have clinical duties as well. My present leadership is really supportive of my academics, and they have supported me even coming here. What would you think, or what are some suggestions that you would offer in terms of myself and other APRNs making sure that we are represented and our work performance is highlighted within our communities?
Well, if you, you know,
practice.
it does take a while once you get protected time to begin. I would recommend that you start to do published research, that you do research and publish it, because there's probably not enough in the literature to even back up your demands for more time, because you don't demonstrate your value if you can't publish.
Correct.
And you can't publish if you don't have the time, the protected time to do it. So first step is getting that time. And the second step is doing that research and publishing. I can't tell you enough how important it is to publish what you're doing. Because when we look in the literature for evidence, it should be there and it's not. We're not
Yes.
seeing it. So please publish. Publish what you're probably doing excellent work and your outcomes are probably off the board, but no one's seeing them.
Yes, it's
And
not
you
captured.
can't demonstrate your value unless we can see that you have done this. And so promise me you'll publish.
Oh, yes, I will try. I'll make every attempt.
Okay, so what's your name again? Because I got to see it in the literature in 5 years.
Rhonda.
Okay, Rhonda.
So I'm putting on 05 soon, so
Oh,
I'm going to
excellent.
all
Oh,
my,
congratulations.
checking all my boxes, ma'am, so I can get there where you are.
I wonder. You know, when I was a student in my diploma program in the 70s, I have to tell you this. I had my OR rotation, so I was going into the OR as a little student nurse going in the OR. And there was a woman that walked down the hall, and my friend said, "That's a CRNA." And I said, "What's a CRNA?" She goes, "That's a nurse anesthetist." And I had never heard of a nurse anesthetist. And then she said to me, "Guess what she makes in money?" I said, "What?" She said, "She makes $1,800 a month." I said, "Oh my God, I'd never heard of that much money in my life. $1,800 a month?" That was like $1 million. I thought, so I'd never heard of a CRNA, and I didn't realize they commanded that much money. So I thought that you might be interested in that story from my past. So testing my beliefs. Come on, challenging my beliefs. Somebody must believe differently than what I'm saying. Oh, are you going to challenge me? Oh, good.
Not so much challenge. I'm going through the bachelor's to doctorate, and I'm also a VA nurse in Martinsburg, West Virginia. So I'm in the same
Wonderful.
VISN. And I don't see very many nurse practitioners in Martinsburg at all. I think I know of one
Why do you think
or
that
two.
is?
Well, it seems like I'm going to be coming into this huge good old boy system. And I was wondering if you have any experience of challenging beliefs that aren't necessarily true, coming into as a nurse practitioner, if you had any difficulties.
So are you using a scholarship, a VA scholarship?
I'm going to work on that this fall.
Okay.
The next NNEI comes up.
When you made the decision to go back to school, did you talk to your leadership about a position for you upon graduation?
No, I didn't, because it's going to be like a 6-year-long program.
Okay.
So I was going to. It's not too soon.
You know, ask them, let them know you're graduating, you're going to be a nurse practitioner, and so that they can create that role if there's none there now. They should be able to do that. And you know, I'm in Outlook. Please call me or email me, and we can talk strategies. But prepare your leadership for your coming, and let them know what you're able to do. And you know, by the time you graduate, if they haven't already found a role for you in PACT, are you going to do primary care or specialty care? Do you know yet?
I don't know yet.
Okay, so depending on where you are, say you decide to do specialty care, talk to the physician leadership in that specialty care area and let them know about you, and help them understand that you're coming so that they prepare a role for you. If you can show them the work you've done, and you will be required to use your work at Martinsburg, which is great, and if you can improve care and outcomes at projects while you're a student, that would go a long way in showing your leadership what you're capable of doing. Then they should be begging. They should be calling you. But you know how it goes. So use quality improvement projects while you're a student. Use Martinsburg. Improve care there while you're working, and then show those outcomes to the leaders so that they will find that position for you. And you almost have to create your own position, and that's okay. You can create your own position. You need to do that.
Okay, thank you.
Yeah, unfortunately the path's not always paved, and they're not welcoming you with open arms. Sometimes you have to go in and say, this is what I can bring. We're not always good at telling folks what our value is, but that's part of being a leader too in nursing, I think. Other questions? Oh, here comes one. Any CRNAs in here? I have such respect for CRNAs.
Oh, it did. Turned on. Hi, I'm Kathleen Hewitt, and I work for a medical association. I'm very overwhelmed by the number of nurse practitioners in the audience. I'm not one. I think I might be the only one. Is anyone else out there not a nurse practitioner? Okay, I'm not alone. I always thought you guys were the smartest people in the world, and you are, I'm sure. In my role, I do work at a medical association, and primarily physicians, although there is a nursing contingent growing among us. Could you talk a little bit? One of your beliefs was that we should be the ones to change clinical practice, not others change it for us.
Correct.
I struggle a little bit because of the focus of some nursing leaders, many of which are in this room, certainly yourself, of where our focus should be. In one sense, I'm sure in your role, you are looking at your nurse market and how you can elevate them and bring research into clinical practice. But I also see the role of nurses, it can be much broader from a healthcare perspective.
Yes.
And not only stopping at nursing.
Yes,
And I
yes.
want to make sure that this program, at least for me, is able to extend beyond nursing because I have
Yes.
the unique ability, as well as others, to be able to impact from a broader perspective. So could you talk a little bit about that?
Yes, and I'm so glad you said that because it made me think of something I had forgotten. One of the things that we battle in the VA is that we try very hard not to only identify ourselves as nurse executives, but healthcare executives. When you get to the level, especially where I am, if I continually call myself a nurse executive rather than an executive who happens to be a nurse, I work for nursing, but I work for patient care and I work for healthcare. And if people only see us being able to respond for nursing because we only speak about nursing and to nursing, then we are immediately put into a category. And those high-level jobs over physician practice and nursing practice and allied health practice escapes us. Physicians get those positions because they're often seen as executives. Oops. Executives. So they're seen as, they speak for healthcare when they speak. We speak for nursing. So what's up with that? We can't just speak for nursing. You're exactly right. I'm so glad you made that point. I see that every day, and I completely forgot about that because we talk about that a lot. We try hard to represent nursing policy, but not only represent nurses. We represent patient care. And we're experts at patient care, right? But we open our mouths and we're only answering for nursing. That's how we're seen. So I have to be very careful. I have to speak for healthcare. And I have not to be afraid. And if that's challenging a physician practice or a medical practice, then so be it. We challenge that because that's a unidimensional discipline. Only for some reason, everybody thinks they're the be-all and end-all to healthcare when actually we are equals there. We have a view, a perspective of patient care that is so complementary to medicine. It's brilliant in the way it was formed. You know, our holistic systems focus, their illness focus is a perfect complement. And as nurse practitioners, you actually embody that in one person. So actually that must be a challenge for you constantly when you are trying to do that balance, that nurse and physician medical model and nursing model together. But think about what a perfect practitioner. And I think sometimes people are jealous because we can pretty much do a lot of things. Our pharmacy colleagues in central office feel like we're always encroaching on their territory because guess what? We can manage medications. We can manage chronic patients with medications. And they go, well, that's our job. Yeah, that's true, but there's not enough of you to go around. So we're everywhere. So we're doing some protocol guidance right now so that RNs can manage medications with chronic diseases. So we have to begin, but to start that, we have to speak for healthcare. So that is a very important piece to remember, that you speak for healthcare when you go out. As you're a graduate of this school, you see yourself as a healthcare provider and not a nursing provider. Don't forget your roots in nursing because nursing is an exquisite practice, but don't only speak nursing. Speak healthcare. That's a huge thing, and that's a very important thing. How am I doing on time? We have about 10 minutes. Oh, okay. Pardon? Oh, please. Am I going to get graded? One of the hardest thing about going to school is that they gave me a grade. Oh, no.
If you were getting a grade today, you get an A+.
Oh,
Don't you
oh,
hate it?
I'm so happy.
Don't you hate it? But as I've listened to you speak, I had a flashback to the knowledge management course in the DNP program. And one of the things that you talked about in one of those sessions was that physicians oftentimes use data
Yes,
to
that's
make
right.
a point.
I remember that.
You remember that? I mean, you
Yes,
talked
all the time.
It was fabulous because what you did was you talked about how you would go into meetings, and what you realized was that physicians always had figured out how to use data to make a
their
point.
point.
And that
That's
why
right.
was it that nursing didn't approach, right?
didn't.
Approach the issue in the same way. Can you speak to that issue for all of us?
Well, you just did a great job. Yes, I guess it's probably, I don't know, does that resonate with you guys? It took me years to figure that one out. So sitting at the table, you're exactly right. If they wanted to promote a program, an initiative, they came armed with the data. And I'm sitting there going, ooh, I don't have that data. So that occurred to me, honestly, if I had done that, I think back in my mind, if I had done that on so many of my initiatives to show that data, then people listened to that. People listened because that goes along with they didn't want my opinion. They really wanted to know what the evidence showed. And that's where my doctoral education really helped me immensely. So yes, I agree. Collecting data, first of all, you need to have time to collect data. You should collect your own data, or you should know how to get the data that you need. Then if you're not good yet at analyzing the data, find somebody who will do it, because there's lots of folks who are good at analyzing data. And then also graphing that data. It's an art to using data. It's there for you, but you gotta know what data you need, know how to display it so you can get the message across, and make sure that it's valid data, that it's credible, valid data. If you do that, they will see you as healthcare executives. They will see you as speaking for healthcare. You are no longer limited to nursing. Now, nursing, if you're trying to prove a nursing point by what nurses bring, then the nursing data is exactly what you should be using. But don't limit yourself just to nursing. But data, that is something that, I can't believe I forgot that too. That is a very important point. That's a key point. Moving beyond.
Moving beyond an anecdotal.
Yes. It gives you the confidence.
That anecdotes and stories
Yeah.
are used heavily to influence and impact. And certainly, I think of my time on Capitol Hill and how stories were used there.
Yeah.
But at the end of the day, the individuals like the Mary Wakefields of the world, who
Yes,
heads up
that's right.
as a nurse, who heads up HRSA, and Marilyn Tavener, who's at Centers for Medicare and Medicaid Services, and Karen Ott, and all of the individuals who are in leadership roles at high levels have figured out that data matters, and if you can tell a story using data, you have a more significant impact. And I just loved
Yes.
what you brought to the classroom to help all of us to think about that issue.
Thank you for saying that, because I had long forgotten that was an issue for us at the time. It still is. We have so many other issues that I forgot about that one. So I think I only have maybe time left for one other thing, one question.
This is very brief. Dr. Would you help us support the call for full practice authority by sending something back to GW, so especially those of us in the APRN community can go to the comment section?
Oh, that's a great idea. Okay, so when our policy, which is now going to be a regulation, gets into the Federal Register, I will send a link. Maybe you can enter your public comments. That would be terrific, because we need that level of support. Some of our physician colleagues have been vicious in their. I won't mention any, but there are some anesthesiologists who really, undoubtedly they see it as a loss of compensation for them. So they came out heavy, hard, and unrelentless in their opposition to our policy for CRNAs. But that's okay. It's okay, because you know what? We're actually, a lot of our physicians in VA understood exactly that they were not coming from a quality and safety, which they said that they were. There was no evidence. And so there was no evidence. There was no data that they could bring to the table to show that cRNAs gave less safe care. So their argument was pointless. So they lost ground when they came to try to command that. So data really made a difference there. So I will send the link when our regulation gets into the Federal Register, because we really would like to have that. We're kind of pleased that it's going to be a regulation, because if it's a policy, it could be overturned, but a regulation can't be overturned so easily. So having APR in practice, full practice authority for VA nurses, having it as a regulation is probably a better way to go for us in the long run, so we're pleased. Well, thank you so much. I didn't mean to take the whole hour. I was going to try to give you a break here. But I enjoyed this thoroughly, speaking with you. I look into the future. I say, my daughter is a nurse, is an RN at Children's Hospital, and she's going to be a P&P someday. I'm so proud of my daughter. And but I look into my future because I go, oh, he's the PP one. Are going to be taking care of me when I'm elderly. So if I get wheeled into your long-term care facility, remember me fondly, please. Thank you all. Good luck.